and today's talk will be about intermediate uveitis. And just only before we have starting, we can ask ourselves, how much of uveitis patient that having intermediate uveitis in general that we are looking? Is there any difference between tertiary eye hospital or clinic and ophthalmology common practice? Do we have any concern about age and difference in the sex of patients? So these questions are important to. So let me to ask them. Reason who is working already in the ER and seeing a lot of uveitis patients. Do you think that intermediate uveitis is really a common type anatomically of uveitis? Just to see any one of you. وليد انت اللي قدامي.
I don't think it's that common. We see it, but it's not common as you
So it's not that disease could be presented as an acute stage, okay? Could this lead to permanent visual loss if neglected?
Yes.
Yes, okay. What are these things? What are the things that could be? How it is you can differentiate between severe anterior uveitis and intermediate uveitis? This is an important thing that you have to look for it, because sometimes it could be, difficult to diagnose intermediate uveitis from severe anterior uveitis. Is there any overlapping sometimes? Yes, there is, and this till now not yet being classified in uveitis practice, because we have cases could be having anterior uveitis with intermediate uveitis. So we have to go. So today we'll talk about that. So let us look for the, what is intermediate uveitis, intraocular inflammatory syndrome that involving vitreous. So one of component, we cannot diagnose intermediate uveitis without vitreous involvement. Second is involving peripheral, retina and bursa ciliaris. So this is the, tissue that could be involved with any patient with intermediate uveitis and mainly vitreous. Then this patient might be presented with minimal or no anterior segment, or coretinal inflammatory sign. So this is what's common. You cannot, diagnose patient with intermediate uveitis and the patient having large, coretinal, retinitis or multifocal choroiditis. This will be exclude the diagnosis of intermediate uveitis. At the same time, we have to having the ability to distinguish between pure intermediate uveitis and panuveitis, because this could be mixed to you and then you can lose the differential diagnosis. Usually having a chronic course might having or lead to permanent visual impairment and could affect children and young adults. Intermediate uveitis or barsophrenitis, this is two terms that remain confusing and imprecise. Barsophrenitis is a subset of intermediate uveitis. So take intermediate uveitis, subset of it, it's barsophrenitis. But usually we have to make sure that there is no, reason for intermediate uveitis. If you have the reason, you cannot say it barsophrenitis. The other things that we need to know about it is that usually having snow banking when you compare it with the regular or idiopathic intermediate uveitis. And usually this is the hallmarks of the differential from the an idiopathic intermediate uveitis. So when you have a patient having for example Bahjat disease or tuberculosis and presented with intermediate uveitis, you cannot say that this is an barsophrenitis, although that you can see the snowballs and snow banking. And usually one of the things that it could be associated with worse prognosis. So diagnosis of barsophrenitis, idiopathic, intermediate uveitis in form of barsophrenitis usually carrying poor prognosis. Let us look for some, epidemiology about the disease. So the incidence of the intermediate uveitis, it's 4 to 8% of all uveitis, cases. When you are looking for uveitis practice, like what we have in the uveitis clinic, usually 10 to 12%. And usually in children, it's representing 15% of uveitis in pediatric ages. It could be having from childhood to 4 decades, and usually no gender, no race or geographical prediction for the disease of intermediate uveitis. When you are looking for the further, characteristic or characteristic, usually bilateral in 70 to 90%, and 1/3 of patients might starting with unilateral and then confirmed to be bilateral. The onset usually having bimodal distribution at the 2nd and 3rd or 4th decades, and duration usually long, often standing more than 15 years. 10% of patients improve over time, and this is good, signs of the disease, and 30% of the patients have a stable course. So this is when you compare it with the, more aggressive disease like Bahjat disease or, PKH with ban uveitis, intermediate uveitis carrying good prognosis in certain cases. The association usually with HLA having, it's non-specific, but it was found that with barzillanitis, which is a subset of intermediate uveitis, might having HLA-DR2. There is a big relation or strong relations between multiple sclerosis and intermediate uveitis. So the prevalence of multiple sclerosis in intermediate uveitis is almost 15%, while in patients with intermediate uveitis, multiple sclerosis is almost 27 to 30% of the patient. So we have to keep these relations. When you have a patient, especially young, females, you have to correlate it with the intermediate uveitis and multiple sclerosis. So if you have a patient with multiple sclerosis, we could expect that 30% of the patient might having intermediate uveitis. In a patient with multiple sclerosis, multiple sclerosis, almost 15% of the patient they might have intermediate uveitis. In hairy KKH, we have survey, and we find that the intermediate uveitis, almost 12.8% of the patient might having intermediate uveitis. What are the causes of intermediate uveitis in our community? It's almost 76% are idiopathic patients. So we have almost common that to have barzillanitis among these patients. Multiple sclerosis as cause of intermediate uveitis, almost 12% of the patient. And then we go to the infectious causes. We have presumed enterocardial tuberculosis is almost 7% of the patient. Bahjat disease is 3% of the patient. Sarcoidosis almost less than 1, because it's not common in our countries that to have sarcoidosis when you compare it with the Eastern, or even the Western peoples. The sarcoidosis is too common there. So put this in your mind. Now looking for the symptoms of the disease, it's not unacute, it's usually subacute or chronic. It's having an insidious onset, and the most common symptoms usually floaters and blurry vision in this patient. Why they have floaters? Why they have blurry visions? We have to explain it. Floaters, because they're having a lot of uveitis, and blurry vision, this patient might have cystoid macular edema. So this explains why this patient could be presented with floaters or blurry vision. So just put that in your mind when you're having a patient and you suspected having uveitis. Think about the symptoms and try to analyze it to get the real problems that with this patient with uveitis. Might having sudden loss of vision. Why? Here we have to think about the complication of the disease. What are the most common complications of the disease that you have it? This is not that obvious, but thinking something. This patient might having, we said, multiple sclerosis, might having peripheral, ischemia, might end by sudden vitreous hemorrhage, and that could lead to, sudden visual loss. Or sometimes they having high intraocular pressure, and that could be lead to sudden, blurry of vision. Sometimes, this patient having, chronic cystoid macular edema lead to permanent, atrophy of photoreceptors, and this is irreversible, visual loss. Glaucoma, as we mentioned, sometimes this patient might develop posterior subcapsular cataract, and this is lead to blurry of their visions, and this is need to be treated as the eyes is getting quiet. Let us look for the signs of this, among the different, anatomy of the eye. Let us start from anterior segment to the posterior segment. So when you're having a patient with the intermediate event, what do you expect to see in their, conjunctiva and externally? Most of these patients are having quiet eyes. They don't have a lot of, lesion when they are looking for anterior segment. What do you expect them to see with the patient with the intermediate uveitis? May they have KBs, right? May they have band keratopathy? Might they have KBs? So let us to go over that. Usually infrequent when you compare it with the real anterior uveitis, but there is. Usually they have mild to few small round white KBs, as we see in these cases. Here you can appreciate this area. So this might be one of the signs of the intermediate uveitis. Put it in your mind. Not all the times this is an anterior, but this is reflecting the anterior activity of intermediate uveitis. So we have, as I told, spectrum, okay, of intermediate uveitis having more activities anteriorly, so that it could be presented as KBs and anterior chamber reaction. Where you can find this is when you have patient presented with large KBs. You have to expect it in a patient with, children, multiple sclerosis, sarcoidosis. And I can add for that is the, tuberculosis. It could be presented with mutant fat KBs. It's not just only anterior. It might having intermediate uveitis. MVI could be, yes, in a patient with long-standing disease that not treated or neglected. It could be presented with prominent either iris blood vessels or neovascularization, hyphema sometimes. So put that in mind. In advanced cases, might be having increased intraocular pressure. Why? Because of peripheral anterior synechiae or posterior synechiae or occlusions, or even though that secondary to response of the steroid. Gonioscopy is important in this patient and could reveal peripheral anterior synechiae, iris medules, angle neovascularizations. So it's important in a patient with intermediate uveitis to have gonioscopy at least once. Posterior synechiae, yes, but it is not common as anterior uveitis, but it could be. So that cannot say that patient with posterior synechiae is not having an intermediate uveitis. There is an entity called an autoimmune endotheliopathy. This is very rare, but you can see it, as in the area of the peripheral part of the cornea, as you see here. And this is actually located linearly arranged KBs at the edge of normal or abnormal, like what we see here. And we call it Hudodist, types of, endotheliopathy. This is very rare, but it could be confused with, tuberculosis, Epidemiology keratitis. It could be with, syphilis. But put it in your mind when you have signs like that. Think about possibility of intermediate uveitis. Again, late finding of the anterior segment, it could include peripheral anterior synechiae and posterior synechiae, as we see in these cases, band keratopathy, as we mentioned, and posterior subcapsular cataract. Posterior subcapsular cataract, when you compare it with other types of cataract, is common, and it's almost 15 to 20% of the patient with intermediate uveitis might having posterior subcapsular cataract. This is not because of steroid, but because of the disease itself. Glaucoma, 8% of the patients, and usually it's related either to uveitis or steroid use. Posterior segment, it's important to realize that the main hole and the main signs to diagnose uveitis, intermediate uveitis, usually vitritis. Without vitritis, we cannot reach the diagnosis of intermediate. If you have a patient with peripheral vasculitis, you cannot say this patient is intermediate uveitis unless you have some evidence that support the presence of vitritis. So vitreous inflammatory infiltrate in form of vitritis, and try to be examining your patient a lot to differentiate between your real vitritis and vitreous condensation or debris. How could you differentiate between these entities? Because sometimes it's too difficult. When you have organized vitreous hemorrhage, if you might be vitreous opacities. If it is, patient having, amyloidosis, it could be having. So how we can, this is an important, and this is the confusion and usually calling the vitreous, that uveitis specialist to see, is this patient having vitritis or not? And it's important, it's not an easy to appreciate, this is from the beginning of your life, but with the time, I'm sure that you'll be able. How you could differentiate between real vitritis and let us to say with the patient already having, subsided vitritis. Both of them, they're having vitreous opacities. Both of them, that they're having, debris. We have difficulty, among us as retina specialists and uveitis specialists. We have, putting some pictures and make it as a standard to compare it with, but this is not enough. Cannot calculate the, the cells in the vitreous. And it's too difficult for us to say how many cells in the, so we have to read it. You have to look, retrolental, and look for the vitreous. Avoid to go to look for the cortex, because cortex will interrupt the cells, and this couldn't reflect the activity. Look for the lacunae. There, this is the space, between the vitreous cortex, and this is where you have to look for, activities of the cell. For by the time being, most of the, uveitis specialists, they are not looking for the vitreous, except looking for the picture, because it's too difficult to count the cells among the vitreous gels. The other things, when there is, posterior vitreous detachment, look retro, let us say retro vitreal. Don't look in the vitreous, contracted vitreous, because this will not reflect the activities. So when you are looking in the space that filled with the fluid, it's better than to look in the gel itself. That's an important for you, when you have. Sometimes we have, some, let us say, helpful, tips. When you have toxoplasmosis, you will find the vitreous localized, the vitritis. So this could help you to start with, to recognize how to see the vitritis among other opacities. If the most of the debris is inferior, so this is, and the superior part of the vitreous clear, that's when this is not vitritis. So that can help you to differentiate between. When you have a patient with sarcoidosis, with bacchial disease, important to realize, the vitritis. Intermediate uveitis, usually the vitritis is, it's mild. It's not that like others. And so important to admit and to look how to appreciate the vitritis. And we mentioned that it is must for diagnosis of the intermediate uveitis. And when you are looking for these pictures, this is here really reflecting vitritis. You can look here. We have, almost diffuse, vitreous, homogeneous, opacities all over, and rarely that you can see the disc. And so here, this is could help you to differentiate between other. If it is jet black, then it's not difficult for us to do. We can do some ultrasound, could help, and can adjust what we see, but not always help, because this is, it's not an objective. It's not, that it's not subjective, sorry. It's not an objective. Usually, just estimate it. So it's difficult usually to focus in such ultrasound or disease, and you say, this is another patient, you can look for the retrolental, but usually could help, This is another patient, you can see how much and how the clarity, and you can see this is, less degree of vitritis when you compare it with the, left hand vitreous. BVD common, and this is because of recurrency of the vitreous inflammation, and you will try to look for worsening and to look for it. Sometimes when you are just focusing in the retina, it might not be able to appreciate the posterior vitreous detachment. So look for, put this in your mind when you are. Vitreous condensation, snowballs, called it ant eggs, usually small ones, and you can see it like that. These are the small ones, okay? See how much is? The characteristic could be small, large, medium, could be, correlated together. So make sure that you are. And what is the, location of it? Most of the time it's located in the jury, but it could be 360 degree, and usually between the interface between vitreous and retina. So it's not retina, it's not just purely. Sometimes with posterior vitreous dilation it could be blood out of the retina and just floating. So put that in your mind. Not that mean, you know, another patient how see bizarre shape, large one, getting, you know, together. See how it is fluffy, oily in color. Another patient might resembling, you know, candida. This is an inferior and obvious, I called it, you know, posterior hypobian sometimes. Then we have the snowbanks. And we mentioned that snowbanks usually, you know, at the ora serrata, you know, and could be localized or could be extending 360 degrees. See it? Sometimes lead to fibrovascular perforations and lead to peripheral tractions, holes, and either exudative or combined retinal detachment. Sometimes you have to ask your patient, and you have to do as well, a scleral depression to appreciate presence of snowbanking. Peripheral vascular changes, either active vasculitis or sheathing, or sometimes you have sclerosed blood vessels. As we see, this is an active one, having cuffing. Some of them in the in the stage of resolutions. Some of them already being resolved. See, when you do fluorescent angiography, you can see the peripheral non-perfusion. You see the area of collateral, and sometimes might be having an active neovascularizations. So this is the patient with the intermediate uveitis, the snowballs, and when you do fluorescent angiography, you can find a lot to appreciate. Doing fluorescent angiography could help to diagnose the cystoid macular with vitaloid shape, fluorescent angiography appearance, or leaking from the disc itself. This could lead to ischemia, causing vitreous hemorrhage, and more found in children. Another example, as you close view, see this bad, having a lot of inflammations here, and then ended by scars, and starting to be consolidated after treatment. This is the how was starting to have the anastomosis. Sometimes the patient having optic nerve neovascularization was uncommon. In an inflammatory intermediate uveitis, usually they have some sort of neovascularizations, as we see in these patients, and usually associated with exacerbation, and could nicely respond to anti-inflammatory. So when you see a patient with a young child with intermediate uveitis and disc neovascularization, just starting your treatment, no need to do any lasers or that vitrectomy in the beginning. Even though that you cannot see that the view. This is a patient, see, this is the neovascularizations. Is it related to ischemia, inflammations? We don't know. Or is it just only telangiectatic blood vessels growth? As we see in this patient with the treatment, all this could be subsided. See here how much? And after treatment, this is another common complications of intermediate uveitis, macular edema, in 30 to 50% of the patient with intermediate uveitis. So when you are seeing intermediate uveitis, think about cystoid or uveitic macular edema. Could be seen clinically or by using OCT or fluorescent angiography, and more likely in more chronic disease. And this could cause permanent visual loss, as we mentioned, might lead to, if not treated on time, might end it by photoreceptor loss. It could be just only mild, moderate, or even though severe in such cases. Doing fluorescent angiography can show you not only the macular edema, uveitis, but even though the activities and disruption of blood-retinal barrier and choroidal circulations. Macular, sometimes, cases could having some sort of silent, macular edema or dry macular edema, because when you are doing fluorescent angiography, you cannot see that the vitaloid shape, and you could see, as you see here, silent choroid here, And when you do your OCT, you can see this bad type of cystoid or combined type of epiphytic macular edema without obvious, leakage. Another, complications of the intermediate uveitis, including Sullivan, maculopathy, and epiretinal membranes, as you see in this patient, and this is because of recurrency of the intraocular inflammations. Disc swelling is not uncommon to see patients, especially children, that could be presented with intermediate uveitis and disc swelling. 70% of patients with onset of the disease before age of 16 might having, disc swelling. So when you have a patient and having vitritis, chamber reactions, think about intermediate uveitis and look for the cause. It could be the associations. Vitreous hemorrhage, as we mentioned, it could be from the disc, as we see. This is actually, for me, it couldn't be an ischemic MVDs, but this is inflammatory types of neovascularizations, and mostly lead to the vitreous hemorrhage in 3 to 5% of the patients. Sometimes we have traction and might lead to vitreous hemorrhage as well. See how much this is how much active. It's not doesn't have the behavior of active neovascularization as we see in the diabetic patient or retinal vascular occlusions. But actually it is an aggravation of telangiectatic blood vessel at the disc. Retinal detachment, it's not unusual, 5 to 15% of the patient with any type of retinal detachment, either oxidative or traction, or even sometimes lead to some sort of combined types. We divided the RD in patient with intermediate uveitis in 4 categories, as you see here. But because this is obviously mostly to my peoples in the retina, they have to look at either we have low-lying type of RD, peripheral, either oxidative or sometimes small, tiny holes at the area of the small tractions. And this patient might having spontaneous resolution, and usually in the beginning of the course. Type 2 RD, usually having large dialysis in patient with mild or chronic inflammatory course of intermediate uveitis. And then we have type 3 and type 4. Type 3 just usually having rapid progressions of the detachment with neovascularizations, and usually in patient with severe chronic intermediate uveitis. In patient with type 4 retinal detachment intermediate uveitis, usually they have total RD secondary to circumferential vitreoretinal traction in a patient with rapidly progressing types of intermediate uveitis. So this is the types of, anyway, actually this is not that significant, but for as vitreoretinal surgeon, we have to put it because every type of this might having its own prognosis. In the late onset with chronic disease that not treated on time, might end it by pigmentary changes, as we see in this patient, scleral blood vessels, optic nerve, atrophy, and even though this is could be carrying poor vision. Patient with multiple sclerosis at risk of such end stage intermediate uveitis, because this patient usually having component of peripheral vascular occlusions and even having central nervous system involvement. Differential diagnosis, when you are putting things together as a science. Vitritis, we have an autoimmune disease including MS, irritable bowel disease. We have sarcoidosis, Fox uveitis. This is confusing because this is having anterior component and vitreous component. In the past, they put it as heterochromic iridocyclitis, but actually now it is syndrome. So this is what you call it, Fox uveitis, rather than to say just Fox heterochromic iridocyclitis. So put this in your mind. Most of the Fox uveitis, they might be having vitreous involvements. Think about that. Infectious causes a lot, and you see here, we'll not go in detail, but the most important for us, usually TB, Lyme disease, and toxoplasmosis, cat's is the most common causes. Masquerade, chronic retinal detachment could be having a behavior of the intermediate uveitis, amyloidosis, intraocular lymphoma, all this could be present. And this is the most important. If you have a patient with intermediate uveitis not responding well, especially in old age, think about possibility of masquerade. And this could be lymphoma, either CNS, primary CNS lymphoma, or intraocular lymphoma, because the vitilitis is one of the most common presentation of lymphoma. Then if you are thinking about snowballs differential, snow banking differential diagnosis, inferior, snow banking, you have to think about barsabulinitis, which is the idiopathic intermediate uveitis, multiple sclerosis, sarcoidosis, masquerade, and familial exudative retinopathy. If you have circumferential, snow banking, think about sarcoidosis. If you have only focal snowball, think about tuxo, cara, canis, and masquerade like fever or ROB. How you can diagnose intermediate uveitis? It's a clinical diagnosis and supported by multimodal imaging and fluorescent angiography, or even so sometimes we need to do endoscopy. So clinical assessment should include visual acuity, slit lamp examination, intraocular pressure, and dilated fundus exams. Okay, important. With clear indentations, which is mandatory in any patient that to see 100% it is intermediate uveitis. Minimal workup include complete blood count, differential, and liver function test, renal function test. ACE, as you know, that sarcoidosis is one of the most common. Differential, chest X-ray or CT scan. It depends on the things that you are thinking. In my country here, tuberculosis is common, sarcoidosis coming second, so I will put CT scan more sensitive in these patients. In children, it's difficult to do CT scan, so that's chest X-ray. It could helpful. TB, skin test is important, and to rule out possibility of any infectious, including syphilis. So, intermediate uveitis has been described in association with multiple systemic associations. So important in this patient to have your tailored types of investigation, and the most important rule, infectious and masquerade syndrome. So may work it in that way rather than to go in others. What are the laboratory workup can be expanded up to the clinical scenario and differential diagnosis. Imaging, including fluorescent angiography, and it's useful in determining the presence and extent of cystoid macular edema, peripheral vascular occlusions, and staining of the vessels, walls, and or leakage indicates prevasculitis, and you have to see a lot of photos to appreciate this signs. Retinal vascularizations and optic nerve edema can be recognized easily with fluorescent angiography. This is a patient, as you see, I showed before. You see this. If you look for this, you cannot appreciate. When you do our fluorescent angiography, you can see how much we have leak from the disc. And looking for the macular area and fovea, you can appreciate the batelloid shape and how much of disruptions of blood retinal barrier and deep choroidal blood vessels. Vasculitis is important, as we see in this patient. See focal types of vasculitis. It could helpful when you do our fluorescent angiography. Leak, and this is the disruption of outer retinal blood retinal barrier, and this could help you to assess the activity of disease. Sometimes you cannot see cells in the vitreous, you cannot see a lot of cells in the anterior chamber. Based on your fluorescent angiography, you can adjust your treatment, either this patient improving or deteriorating. So having baseline fluorescent angiography repeating after 3 months, you can see the difference if it is worsening or improving. Another patient with the same issues. P-scan. Sometimes intermediate could be severe enough, or the patient developed cataract, or patient having small pebble with bysterocynica cataract. You cannot see clearly what are the activities there in the posterior segment. So ultrasound could help in such patients. So useful when media are obscured, either by vitreous hemorrhage, by inflammatory debris, cyclitic membranes, or in cases of cataract. So that could help as well to document the extent of vitreous debris retinal detachment, and any cyclic membrane. UVM is important in such patient, especially when expecting to have cyclic membranes, or sometimes ciliary detachment, or even through atrophy. In advanced cases, patient that having ciliary atrophy, that means you cannot risk this eye, so it's important here to have the UVM in such patients. When you are doing your cataract, you need to do IR calculation at the same time. And this is UVM cases, and you can see how much we have cyclic membranes and thickening of the ciliary body. Another patient with multiple areas of retinal detachment, retinal detachment, patients with thickened choroid. In such patient, it could help you a lot. So almost this is what we talked already. Fetal-retinal adhesion cases with fetal-retinal membranes, like with maculopathy. OCT is helpful, but you need to have clear media, either the lens, the cornea, and even though the vitreous. Doing that can help a lot to detect the tiny or subclinical types of cystoid macular edema or uveitic macular edema. Nowadays, not just only to see the presence of macular edema, even though it can categorize uveitic macular edema. This is just only cystoid. It is combined types with subretinal fluid, with diffuse leakage. Is there any retinal membranes? Is there any loss of photoreceptor? All this can help us to predict the prognosis in such patient with OCT. And could help the response of treatment, either just for the topical, systemic, or even though for intravitreal or injection, for anti-VEGF, or though sometimes the intravitreal steroid injections. I think this is already you talked. That's just only examples. So, what are the most important things there? So, the current consensus in the treatment of intermediate depends on based on the visual acuity, extensive, vascularization of the peripheral retina, extensive vasculitis, severe floaters, and early and aggressive treatment is more effective in this patient. So, vision of the patient. If the patient having vision of 20/25 with less, signs of inflammation, this patient could be observed, or just only topical medication. If the patient having an extensive vascularization of the peripheral retina, it could be indicated, some peripheral, ischemia, traction. So now how we have to react in different way. If the patient having severe, extensive vasculitis or, floaters with vitritis, I have to treat this patient in another way, either by local treatment or intravitreal injections, or if it's bilateral aggressive, I have to go with systemic treatment. So this is how we can usually approach patients with intermediate uveitis. In the past, we have, what we call, Kaplan, regime, which has already been modified and changed to starting with, just only, local treatment in form of subtenon, injection of steroid that escalated to the oral steroid, then cryotherapy if there is peripheral, ischemia or peripheral, activity as I mentioned earlier, and then to go to immunosuppressive. And actually, this is not the way now. Now we are dealing with the patient with intermediate. Bilaterality is important. The younger age is important. The availability of treatment is really is there. The side effect is not that obvious if you're looking for the new treatment like biologics or immunosuppressive medication. So usually this is just to use it to help you. Subtenon or local treatment is not an obvious. Now we have new ways that we have to adapt, which is intravitreal steroid implant like fluocinolone acetinoid implant, or we have an osmodex. So let us to go for the modified Kaplan regimes. Topical, corticosteroid together with regional corticosteroid injections if the inflammation is prominently anterior. So anterior type of intermediate uveitis, go with these types or this treatment. and you can enhance it with oral non-steroidal anti-inflammatory. And if there is a cystoid macroedema or ephytic macroedema, actually I like to use ephytic macroedema rather than to use cystoid macroedema, because cystoid macroedema is subtype of ephytic macroedema. So you enhance it with typical non-steroidal, and you can use the recent types of non-steroidal like Navinac, which is more powerful when you compare it with Ocular. Then we can escalate it to limited times of systemic steroids, especially in recurrent cases. Then escalate it to immunosuppressive medication. Children can be starting on methotrexate, adult with Cellcipt or Imuran, it could help. If this is cannot fit for your patient, then you can use TNF inhibitors in form of Humira or Infliximab. Then if there is peripheral retinal pathology, you can use cryopexy, but nowadays we have good options better than when you compare it with cryo. We can use laser photocoagulations, and then in cases that are not responding or there is an obvious vitreous debris or opacities, then you can treat this patient with Barca planophthalmectomy. And at the same time, this is not just to clearing the media itself by itself. It's one of the methods to treat, and found that patient after Barca planophthalmectomy getting subsided, and even though their systemic treatment getting less and less required. Anti-vascular endothelial growth factors inhibitors. It could be used in a patient with ephytic macroedema, putting in your mind that the ocular inflammation should be under control. If you have vitritis or anterior chamber reactions, try to avoid anti-VEGF, because this could be increasing if the patient having choroidal neovascular, this situation is different, because here the anti-VEGF is the best when you compare it. I would like in these cases, I can go with more, steroid implant when having the choice. This is a patient with obvious, cystoid macroedema in both eyes, neovascularizations, and being on systemic treatment, but the response was limited, so that the patient injected with the anti-VEGF, and after, initial treatment, one eye only, look for that response in the other eye even though. So clinical course and prognosis of intermediate uveitis, we group it in more than one group. Group 1 usually they have mild, which is representing 31% of the intermediate uveitis. We have group 2 mild but chronic in the same time, it's almost 50% of the patient of intermediate uveitis. Group 3 where they have severe and chronic course of intermediate uveitis, and representing 15. So this is the most group that need to put on mind, and they have usually the easy, you can approach them and treat them on time. Group 4 where they have refractory and progressive course, and this is only representing 10%. I think with the new modalities of treatment, this group now is less than even though 10% of the patients. What are the things that could be carrying poor prognosis? Barca by itself is carrying poor prognosis. The presence of phlebitis increase the risk of multiple sclerosis among our patients, and even though optic neuritis. And approximately 50% of intermediate uveitis patients have visual acuity of 20/30, which is really good to have that at presentation, and majority of them retain 20/40 post-treatment. So don't hesitate. Don't leave your patient just only to get out of your clinic while you have the ways to help them. So the prognosis of pediatric patients with intermediate uveitis was considered unfavorable, secondary to late presentations in the course of the disease and the inherent difficulties in the treating such patients with immunosuppressive medications. In conclusions, intermediate uveitis represent 10 to 20% of our uveitis patients. You have to evaluate for associated systemic disease. Diagnosis is primarily based on the clinical findings, and you have to look for typical vitreous infiltrate and snowballs and snow banking. And you have to remember the potentially blinding complications of intermediate uveitis, including glaucoma, cystoid macular edema, macular Uveitis, and retinal detachment. Modified Kaplan regime is the most accepted treatment modality for intermediate uveitis. Early and aggressive treatment usually carrying good prognosis. And lastly, visual rehabilitations through cataract surgery with or without barzaplanopectomy is safe methods of treatment in these patients.